This program is brought to you by Emory University.
Good morning and welcome to Cardiovascular Grand Rounds. Today's speaker is Dr. Arshed Quyyumi, who's professor of medicine and co-directs our Emory Clinical Cardiovascular Research Institute. He'll be speaking on predicting risk in coronary artery disease, and we'll discuss whether we're on target. Arshed?
Good morning. Nice full room. I must say I had to start half an hour before I usually start just to get in on time. So I think everybody's on their way, hopefully. So I'm going to talk about this largely relying on the data that we have been generating over the last several years and discuss with you where we are now. So here are, in red are the grants and things that we got that would be relevant to the presentation. So I'm going to just sort of overview with you where we are in terms of predicting risk or determining risk in our patients. And the first group that we want to discuss are really people who we don't know. So these are, as it were, the general population where we have no idea whether or not they have cardiovascular disease risk. They may have some subclinical atheroma, very early stages. They're certainly asymptomatic and they're wondering whether they are at risk of developing coronary artery disease. And the standard recommendation for this group is that we use the Framingham or the ASCVD risk score and determine risk. And I won't go through the components of it. We all know this. We do it on a daily basis. And sometimes we come across people whose families are at higher risk and so on, and we start looking for all these other factors that are listed there, like Lp(a) and homocysteine and particle sizing, HDL function, and so on. And the reason we do this, and this is all now guidelined, is that if you reach a certain Framingham risk, then we can start them on therapy. So there is a purpose in doing this analysis, because then you know that if you reach ASCVD risk score of 7.5%, 10-year risk, then you can increase. You can start discussing whether you should be on aspirin and statins, and you can do risk factor control. So here is the paper that Peter Wilson and others wrote almost 20 years ago that described the Framingham risk score. And I'm just highlighting a few things. It was 5,300 people living in Framingham, largely a white population. And the CHD event rate that they built this risk score on was a composite of cardiovascular death, MI, angina, and unstable angina, and there were 600 events, and this population was followed up for 12 years. So the event rate was 1.3% per year in men and 0.6% per year in women. So really low risk population, if you call that low risk, and this is a composite event rate. So this is, if you just think of hard events, death and MIs, then it'd probably be less than half. It doesn't actually clarify in this paper how many were heart events and how many were angina events. So this was thought that this kind of lumps people into large categories. It really doesn't personalize risk in any way. And so calcium CT score came along, and this was popularized by studies such as this. This is a MESA study, which is a multi-ethnic study of asymptomatic population. And you see this is a group that's over 45 years of age. And here is the paper that describes that calcium score above 300, you have far higher risk than if it is 0. And then there are all these categories in the middle. This is death and MI rate. Once again, if you look at overall event rate in this population is 1/3% per year. Total events that were measured were 89 death and MI events after about 4 years of follow-up. So these are just numbers to bear in mind, showing that the risk of this disease in the general population is relatively low, and you have to follow them up for 4 to 12 years to begin to decipher things. And it is somewhat like looking for a needle in a haystack. So what's the role of biomarkers here? That's what we're talking about today. So there are now analyses done using a bunch of different biomarkers. So I'm going to get into this whole idea that we need multiple biomarkers to begin to decipher, just like we need multiple risk factors to measure risk. You probably need multiple biomarkers to really decipher risk. And this is a study also looking at the Framingham Risk Cohort. And they have measured these various biomarkers, ST2, GDF15, high sensitivity troponin, BNP, and CRP. Some of these you may not have heard of, but you know high sensitivity troponin is reflecting myocardial stretch, just like BNP is, or ischemia, and this is an inflammation marker. These are probably a combination of inflammation/renal markers. And you can see that it does differentiate people into these risk categories. Fourth quartile have higher event rate in terms of major CVD events, but mainly from heart failure. So what this discovers, even though we are looking at death and so on, is heart failure. I've lost my screen here. This is just a quick look to see what these risk score is telling us. Is largely the onset of heart failure during follow-up, but if you look at other cardiovascular events, it's not very good at, for example, diagnosing coronary disease and its progression. So that's one group of individuals that we are asked to look at and determine risk from, and that's your general population. They may have some risk factors, and we have a way of doing it, and there is a question as to who should have assessment beyond the Framingham risk with CT calcium scores and perhaps biomarkers, but you can see the value of those things is somewhat marginal, and you really have to test a large number of people to find the one or two perhaps that who are at high risk. Then we come to people who have coronary artery disease, that you know for one reason or other that testing has been done, or they have symptoms, and you're determining how much disease they have. And generally what we do here is not only assess risk factors, but we would do stress testing, and if the stress test was positive, you would do angiography and then revascularize as necessary. So that's the standard way of dealing with this. However, what we are trying to predict in these individuals is really progression to acute coronary syndrome, right? So you're asking not only just for relief of anginal symptoms, but wondering who is at high risk for future acute coronary syndrome and or cardiac death. So if you look to answer that question, is ischemia testing useful in this stable group of people with coronary disease to predict outcome? You could look at Courage trial, which, as you know, looked at people who had coronary artery disease, which was significantly narrowing coronary arteries, and ask the question whether the amount of myocardium that was in jeopardy on stress testing was associated with worse risk, and the answer was that it wasn't. And there are lots of other studies showing this as well. But then when you look at amount of coronary artery disease in the same trial, so this is now using a risk score of coronary anatomy. So 0 to 5 is less disease, and 14 to 17 is much more disease. So 1, 2, 3 vessel or so, something equivalent to that. So the magnitude of disease matters. The amount of disease or the burden of atherosclerosis is important, but how much ischemia it's causing appears not to be that determinant of future risk of death and MI. But notice that once you have this population with coronary disease, the overall event rate is roughly around 10% per year of death and MI. Very different from the general population where the risk is less than 1% per year. So in predicting risk then, you have the general population where you have very low risk. You have the population with coronary disease where you have much, much higher risk compared to this population. And then here we are asking not only the risk of acute events like death and MI, but also how much does this disease progress over time. So stable progression, this is gradual further and further narrowing of the coronary arteries versus the acute progression. So two different types of progressions that we deal with. And here the question again is, what's the role of biomarkers? So to address this, we have created, for a variety of different reasons that we created this, but we created this biobank 10 years ago. And this has now recruited up to 7,000 people who are from the cath labs here, so in the Emory system. So anybody who consents to have their data collected and their blood drawn and saved are part of this study. Mean age is about 63, and they are followed. So somebody calls them, and their records are looked at to see if they are having further events. The death and MI rate is 12% over 2 years, and revascularization rate, this is unplanned, meaning not at the time of the angiography, but subsequent to that, is about 11% over 2 years. So that's the event rate in this population. This is what goes through our hands, if you like. And this is what the cohort looks like. The first 3,500 people, mean age 63, 2/3 are men, almost 80% are white. And here's all of these other numbers, but diabetes in 1/3 of them. Most of them have had hypertension diagnosed, dyslipidemia in majority of them, and about 60% have smoked at some point. And myocardial infarction at presentation, so NSTEMI or STEMI, would be in 12% of this cohort. Previous history of myocardial infarction on just less than 1/3. And this is the outcome of these people. This is that 12% in 2-year risk. So a relentless occurrence of death and MI, despite maximal therapy, despite the fact that they all get revascularized in the way they should when they come, there is this event rate. And when we look at the usual factors that we measure in these people and ask, what are the independent predictors of outcome, we don't come up with factors that are Framingham Risk Score measures. These are the measures of risk of future acute cardiovascular events in a group of people who have established coronary artery disease, who are being currently managed with the medicines that they are managed on. So age is an important risk factor. Diabetes, history of smoking, low EF matters. If you had an acute MI at presentation, it matters. And if you have significant disease, meaning obstruction compared to those who are not obstructed, because a lot of our patients, about 1/3 of them, have non-obstructive disease. So if you look at these 6 risk factors, as it were, the measures that we find are independently predictive, and divide this population up according to that. So now you're looking at the usual clinical measures. 0 to 1 of these factors, you have much better outcome than if you have 3 or more of these risk factors. So you can distinguish risk even based on these measures that we get at the end of the case, as it were, the cath lab, and determine which curve these people happen to be on. So can we do better than this? So here we are, we measure risk factors, we get to coronary artery disease, we now have made some sort of diagnosis at angiography, whether it's non-obstructive or obstructive, and we're waiting for them to have cardiovascular events. We treat them all the same way, we don't titrate anything to anything. And they have these events. And the question is whether we can use pathophysiologic understanding of how disease progresses, that there is oxidative stress in the vascular wall, there is inflammation, the immune cells come in and out, and there is prothrombotic state that allows clot to form, and can we use biomarkers to assess these things that would help us distinguish people from this sort of homogeneous crowd that we leave behind, having intervened on them or not from the cath lab. So how good is oxidative stress as a measure? So we've been measuring these aminothiols, as they're called, for many years. This is done with help from Dean Jones's lab using HPLC methods. Cysteine is the reduced form of cysteine. This is an extracellular antioxidant, if you like, that we have. Glutathione is an intracellular, mainly antioxidant that when it oxidizes becomes a disulfide. And these can be measured in plasma. Oxidative stress itself is actually quite hard to measure because these are very short-lived reactions of reactive oxygen species that then leave signals behind because there are lots of these oxidants, if you like. They can oxidize nitric oxide and give you nitrites and nitrates, and you can measure those, or they can oxidize lipids, you can measure oxidized lipids, or they can oxidize membranes, you can measure isoprostanes in the urine, or you can measure these aminothiols, which is what we have been doing for some time. These are the most ubiquitous antioxidants that we have. Intracellularly, glutathione, like for example, if you add acid to yourself, as it were, you would have glutathione mopping it up, and cysteine converting to cysteine in order to keep the pH the same so the cell can function and not die. So this is what happens to oxidative stress across life. So this is now looking at normal people. These are not people with coronary disease, but just to understand the pathophysiology of oxidative stress in humans. So this is measurement of cysteine. So I've selected these things rather than showing you every single metabolite. But this is increasing oxidative stress. Notice how as we age, we become more oxidized. And the degree to which you are oxidized depends on how many risk factors that you have. If people who are aging healthily will have less increase in oxidative stress with aging. When we measure endothelial function, people who have worse endothelial function measured as FMD, or flow-mediated vasodilation of the brachial arteries, will have higher oxidant stress, lower FMD, higher arterial stiffness measured as pulse wave velocity, more oxidative stress, higher IMT, more oxidative stress, higher diastolic dysfunction, more oxidative stress, metabolic syndrome, these are blacks and whites shown in white and black here, lower glutathione, meaning increased oxidative stress in those who have metabolic syndrome. These are all independent predictors, so other than whatever else is going on, oxidative stress are independent predictors of subclinical vascular disease, of metabolic dysfunction, of diastolic dysfunction. When we looked at a small number of people and their coronary arteries very carefully with IVUS, looking for this vulnerable plaque, then the amount of vulnerable plaque was related to systemic oxidative stress. Coronary flow reserve was related to systemic oxidative stress, meaning low flow reserve in those who were more oxidized. And then even risk of atrial fibrillation is the analysis that Ayman Tahan is currently doing, showing you here that this is an independent predictor of oxidative stress. This is prevalent atrial fibrillation that is in about 1,400 people, about 10% of them had atrial fibrillation. But not only that, if you looked at incidence of atrial fibrillation when we followed these people over time, so 900 individuals followed for 6 years in our database, 11.5% developed AFib, and these are the independent predictors of occurrence of AFib, which is age, diabetes, and heart failure. These are kind of expected ones. But what was also independently predictive was the degree to which they had increased oxidative stress. So all of these might be associations without real any, which may not matter until you begin to ask whether this really matters in terms of future cardiovascular risk. And so here is 1245 individuals who have been followed now for 2.5 years, and it turns out that the degree to which you are oxidized also was predictive of future cardiovascular events. So this is looking at death and MI. People who had high cysteine, meaning higher oxidative stress, had a higher death and MI rate. People who had low glutathione had higher risk, and then the ratio of the two allowed us to almost have a twofold increased risk of cardiovascular death. And it improves the C statistic, etc. And again, this is over and above knowing whether they were diabetics or they were old or this and that. So it's adjusted for all the usual risk factors. So it's like having another risk factor, if you like, such as diabetes or smoking, which all have an odds ratio of around 2 by knowing what the oxidative stress is. And it's not the same as measurement of CRP. So when we looked at CRP in relationship to oxidative stress measure ratio, then these were additive. So these are people with neither high CRP nor high oxidative stress. Best prognosis, these are people where both of those things were abnormal. So more of these functional abnormalities that you have systemically, the more likely you are to be at higher risk. So in summary then, oxidative stress can be measured fairly simply from circulating plasma. It's associated with aging in normal people. It's associated with cardiovascular risk factors, presence of metabolic syndrome. Blacks in general have high oxidative stress. It's related to subclinical cardiovascular disease. It's a predictor of pulmonary hypertension, of left atrial size, of incident and prevalent atrial fibrillation, of diastolic dysfunction, of coronary microvascular function, of vulnerable plaque, and of incident death and MI. So it's meaning of life, all right? And these are all independent of CRP, so it's just not like measurement of CRP. So let's go on and ask, well, how good are these other measures of pathophysiology that we know lead plaque from changing from being stable to unstable? So we all know about CRP, so I'm not going to spend any time talking about why it is a measure of systemic inflammation. There are other factors that we measured, heat shock proteins, which are these proteins that are inside our cells but get expressed when the cell is under stress. That's why they're called heat shock. If you heat the cell, they will get expressed on the surface, they'll break off and circulate in higher concentrations. And they all have different molecular weights, so we measured a few of these and found heat shock protein 70 to be predictive. Fibrin degradation products are degradation products of fibrin. So if you have clot or clotting, then you could have more of these in the circulation. And D-dimer that we generally measure for diagnosis of pulmonary embolus, etc., is part of the FTP cascade, but only part of it, but it measures other fibrin degradation products as well, that assay. And SuPAR is a bit more complicated. It's a measure of thrombosis and inflammation and perhaps other factors, including renal deterioration. So it's a complicated marker, but also very powerful. So we looked at these different markers and some others which didn't work out. So I'm going to show you the ones that are actually prognostic. Again, in the Biobank, and these are 3,000 plus individuals who are going through the cath lab. They have had their coronary disease addressed, and they are all on the same treatment roughly. And they are now going forwards and having events. So if you can divide them by high and low CRP, highly predictive of events, high and low heat shock protein 70, fibrin degradation products, and SuPAR. All highly predicted, largely because the numbers are so huge. Look at the p-values. Now the question is, the other thing was that, and I'm not going through the whole analysis, but all of these biomarkers were independently predictive of each other. It wasn't just like measurement of one was just like measuring something else. So if you put them all in the same model, they were all independent of each other. So here's the prognosis of our individuals, the way we have them now. We can't tell anything, but if you had measured these things and divided them into risk scores as having one of these high or two of these high or three of these high or none, over 2.3 years, as I said, these are the deaths and MIs. So we have more events here than Framingham had when they made the Framingham Risk Score. So here's what happens. These are people without any elevation of any of these biomarkers. They sort of live forever. And then here are people who have elevation of all 3 or 4 of the biomarkers. Particularly these two groups have extremely high risk. So let's compare this with the usual risk factors that we use to determine risk. So you remember this I showed earlier, where you can use the usual risk factors also to distinguish risk. Now, if you add the biomarkers to the usual risk factors, this is what you get. It's a little bit more complicated, but let me just take you through this. So these are people with 0 or 1 clinical risk factors, but the biomarker risk score is 0 as well. So they have very few events. The same group with 0 or 1 risk factor, clinical risk factor, if you have a risk score of greater than 2, biomarker risk score, this is what happens. So they look like people who've had 3 or more clinical risk factors with a biomarker risk score of 0. So this is how much it reclassifies your risk. having the biomarker risk score superimposed on what we know about these in terms of their risk clinically. So here are some numbers to bore you with. Let's just look at cardiovascular death. Each of these biomarkers are not that good, if you like. They vary between 1.5 and 2-fold increased risk, highly significant, but nevertheless. But if you categorize them by combining all 4 of them, then look how much better it gets our risk prediction. 8-fold to 12-fold increase in mortality in people who have all 4 biomarkers elevated compared to those who have none. Another way to look at this is annual event rate. So annual event rate in those who don't have any biomarkers elevated is less than 1, and then in people who have all 4 elevated is 22%. So half of these people over 2 years may not be there or would have had an MI. And we know who they are, but we don't measure it. Who are they and how many are there? So 0 biomarker positive is 1/3 or just less than 1/3 of our population. So we are treating these people all the same way, yet these people really don't need to be treated anymore because we cannot reduce their risk anymore. Yet there are these people, say the 3 and 4 biomarker positive group, this is 1 in 8 of our population who had an exceedingly high risk that are not identified. Now, it's not like these biomarkers work in a certain type of individual. So if you're old or young, or male or female, black, white, hypertensive, et cetera, you have low EF or high EF, they work to the same extent in all of these individuals. So it's independent of the clinical measures of risk. And this is just demonstrating what the area under the curve would look like. So this is the usual clinical measures, gives you this line with an area under the curve of 0.69. And this is how much it's improved the discrimination of risk when we add the biomarker risk score. So the usual risk factors are all of these things: age, race, gender, BMI, smoking, hypertension, diabetes, all the meds that they're on, whether they had acute MI or not, whether you had renal failure or not, LVEF, et cetera, et cetera. So we can now say that above and beyond the conventional risk factor assessment, we can have these measures of simple biomarkers that are looking at various pathways that are pathophysiological that may distinguish risk better. So what about measures of myocardial stress? So remember, all of these other factors were measuring systemic, perhaps vascular pathways. High sensitivity troponin, and we had a talk on this recently, so I'm not going to dwell on this too much, but has been shown to be highly predictive. So this is not the usual troponin. This is the troponin assay that measures levels of troponin below where we call unmeasurable with the current assays that we use clinically. So these are now using high sensitivity assay. So this was measured by Abbott. This is now in people who, in our database, who didn't present with an acute MI. So anybody who had the troponin level, the usual troponin level high, we removed from this analysis because we knew that they had acute MI anyway. So we're looking at people below the detectable range of troponin, or what would we consider normal, and dividing them into quartiles. So below the detectable range of troponin by current assays, you can distinguish risk very well, almost a 4-fold increase in cardiovascular events, death and MI compared to those who had in the lowest. So what if we combine all of these 4 biomarkers with troponin? Well, the curve looks even better in terms of distinguishing risk. So these are people with 0 or 1 of these biomarkers positive, and these are with all 5 biomarkers positive. Once again, it reclassifies risk in an amazing way, and so on. So we've, and I've shown some of this before at different times, so I'm going to show you some more data that we have now been able to work on with these 2 new biomarkers, which is SuPAR and high-sense troponin. So with respect to SuPAR, I'm going to show you data regarding CAD severity, peripheral arterial disease, renal disease, and heart failure. So we asked the question whether we could, whether these biomarkers are also predictive of actual underlying extent of disease. So this is now looking at coronary angiography and dividing them into those who have normal-looking coronary arteries with less than 50% disease and greater than 50% disease. So there is a difference, a higher SuPAR level in those who have higher disease. Now, this doesn't happen with CRP, for example. So it's not like every biomarker tells you this. Then we examined its role in peripheral arterial disease. So among the 5,800 people in our database, there were 17% who had some evidence of peripheral arterial disease, either in the carotid circulation or in the legs or in the aorta or in multiple sites. So we looked at these two groups separately, those who had CAD and those who had PAD and CAD. And people who had PAD history like that had higher levels of SuPAR. And it was higher still in those who had multi-site disease. So this is now SuPAR level in people without any CAD, significant CAD, less than 50%, or PAD. So they had the lowest level. This is people with just coronary artery disease. This is people with peripheral arterial disease. This is people with coronary artery disease and peripheral arterial disease. So a general trend to higher levels. Similarly here, 2 sites of PAD versus 1 site of PAD or versus no PAD. So the more extensive disease there is, atheroma burden, beyond the coronary circulation, the higher the levels of SuPAR. And SuPAR happened to be also an independent predictor of all-cause death in this population. So this is mortality increasing by tertiles of SuPAR. And this is PAD events. So these are not coronary events, these are just PAD events. These are things like amputations and revascularization due to deterioration in the peripheral circulation. What about SuPAR and kidney disease? This paper was published a couple of years ago, and they showed that when we looked at renal function over 10 years in this database by looking at GFR change over time, and divided them according to what the SuPAR level was at baseline. And these lines are showing you the rate of decline in GFR. So notice that people who are in the lowest quartile of SuPAR levels, or the first 2 quartiles, have much lower decline in renal function compared to those who were in the highest quartile of SuPAR. So SuPAR is not only something that is telling us about cardiovascular disease, but also of atheroma burden, peripheral arterial disease, renal disease, and renal deterioration. And this is just showing you how many people develop what we call renal dysfunction when they start off with a GFR above 60. So if they had high SuPAR levels to begin with, they are much more likely to develop renal failure compared to those who start off with normal SuPAR levels or low SuPAR levels, and this paper was published in the NEJM. So what about SuPAR and heart failure? So we looked at a subset of individuals who had heart failure diagnosis made. So this is 1,500 out of 5,000. Patients with heart failure had 20% higher levels of SuPAR on average. And in fact, SuPAR was an independent predictor of a diagnosis of heart failure even after adjustment for all of these risk factors and adjusting for troponins and CRP. So these are people with HFpEF versus HFrEF. HFrEF has more, higher levels of SuPAR. When you look at ischemic versus non-ischemic, ischemic heart failure has higher levels of SuPAR, and this is now SuPAR looking at with NYHA functional class, so people with more severe symptoms would have higher SuPAR levels. And now this is looking at incident heart failure. So this is people who didn't start off with a diagnosis of heart failure, but during follow-up in the database were diagnosed with heart failure. So notice that if you start off with high SuPAR levels in the highest quartile, you have much more likely, almost 10% of them over 5 years would develop heart failure diagnosis. So here's a marker which is not BNP. which is showing us that it is an independent predictor of outcomes in heart failure, also incident heart failure, and of death, cardiovascular death, and rehospitalization in heart failure. This is all separated by SuPAR quartiles. This is independent of CRP, it's independent of high hs-troponin. We don't have BNP in all of these people, but we're hoping to get it, and that'll make it a bit more legitimate in the eyes of the heart failure specialists. Look at the hazard ratio. So in summary then, as far as SuPAR is concerned, it's related to incidence and severity of coronary artery disease, of peripheral arterial disease, of heart failure, and of renal disease. It's independently predictive of outcomes, specifically all-cause cardiovascular death, for hospitalization for heart failure, for PAD events, and for renal failure. And here's this other marker, high hs-troponin. Again, we've had a very nice talk about this and its relationship to future cardiovascular events a couple of months ago. So I'm just going to show you some unique analyses that have been done from our database that adds to the story. So what about coronary disease severity? This has never been looked at. This is what Eamon is now analyzing. So this is now 3,000 individuals separated into those who had non-obstructive disease, single vessel, two vessel, three vessel disease. Notice how with increasing high hs-troponin level, there is increasing severity of coronary artery disease. This is now looking at progression of coronary artery disease, meaning this gradual progression of severity of disease without having acute coronary syndromes. So 717 people in our cohort had repeat angiography. So they came in with their index angiogram, which is when we collected them, and then they happened to come back again. So it's kind of a convenience cohort. It isn't like that everybody got re-angiogrammed. So we could look at this group, and the mean duration of follow-up was 3.8 years before the next angiogram occurred. And we looked at progression of disease by just analyzing the angiograms at baseline and the future. So you could look at this slow progression of disease by angiography. Troponin, high hs-troponin, the progression rate in people who were in the highest quartile was 3.5-fold higher than those who didn't. So this is looking at progression rate of the Gensini score. So Gensini is a way of scoring severity of coronary artery disease. So you can have your baseline Gensini, you'll have your remeasured Gensini, and you calculate how many years later that angiogram was, and you can get the rate of Gensini progression, if you like. And that's what this is showing. So higher your troponin levels, the more likely you were to progress in terms of disease severity. So this is just also one of dramatic ways of looking at this. So this is now looking at people in terms of the severity of disease and their troponin levels. I'm not sure why these signals are changed, but this is the lowest quartile of troponin. This is the highest quartile of troponin. And this is the hazard ratio of having death or MI going forward. So if the hazard ratio for people with no obstructive disease and lowest troponin level was 1, then look at what happens if you had three vessel disease but remained in the low troponin trial. So lowest troponin quartile. So you have increased risk, but it's 2.5-fold. But if you were in the highest troponin quartile, which would be this one, and you had three vessel disease, then you had almost 8-fold increased risk. So not only is the amount of magnitude of disease important in terms of future outlook, but actually the troponin level would also add to that, so that your risk discrimination would be that much more dramatically improved. This is now looking at chronic kidney disease individuals, because one of the things with troponin, remember, is that you get your phone call from the ED and says the troponin is 0.7, and you say, what's the creatinine, right? This is our standard next question. And is the patient demented? That's the second question. And the reason is because, it becomes unreliable in that population, we say. So we looked at this question and said, what is troponin doing in people with renal disease? So this is average troponin level in people with normal GFR, a mild reduction, and severe reduction in GFR. So notice how there is increase also in high-sense troponin. So there is some retention of troponin. And this is looking at troponin in the highest quartile. Once again, number of people who end up in the highest quartile increases with increasing renal dysfunction. But if you look at prognosis or prognostic ability of troponin to distinguish risk in people who had no CKD, meaning GFR more than 60 versus those with less than 60, it's actually far more predictive in people who have depressed renal function than it's predictive in both, but it's actually equally as much, if not more, predictive in people who have depressed renal function. So we cannot ignore high-sense troponin levels in people who have renal disease just because we think it's going to be higher anyway. So what about myocardial ischemia? Because obviously we relate troponin to infarction, and the question arises with high-sense troponin whether this is telling us anything about myocardial ischemia. So this was studied in the MIPS population. So this is this mental stress ischemia grant that we have, where we have studied almost 600 individuals with stable coronary artery disease. They underwent stress testing, both during mental stress, so where they're made to make a speech, and also during physical stress, where they either exercise or have adenosine. So they have ischemia determined both ways by nuclear scanning. About 16% of them had ischemia during mental stress, and 35% of them had ischemia during conventional stress testing. And this was their median high-sense troponin level. So if you look at people who had mental stress-induced ischemia, they had higher resting troponin levels. If you looked at people who had physical stress-induced ischemia during stress testing, these are looking at resting troponin levels. This is not after stress. This is resting troponin levels. They have higher levels. People who have ischemia during mental or physical stress. If you look at the degree to which there was ischemia by looking at the defect size, then there seemed to be a rough relationship between the magnitude of ischemia during mental and physical stress and the degree to which the troponin level was higher. So if we ask, is it an independent determinant of ischemia, the answer is yes, both for conventional stress and mental stress ischemia, almost 2.7-fold increased, or 2.5-fold after adjustment increase in odds of having ischemia if you have high resting troponin levels. What happens to troponin after you exercise? So this is measured levels after 45 minutes of inducing mental stress and 90 minutes after, and this is now measuring 45 minutes after physical stress. So notice there is no this increase was not significant. However, people who had mental stress ischemia just had high levels throughout compared to those who were mental stress ischemia negative. During physical stress, there is an increase, a significant increase in high-sense troponin. This is not because we have microinfarcts when we become ischemic. It's just that's what happens to high-sensitive troponin. It gets squeezed out of myocardium that is under stress. It's not equivalent to having an infarct, whereas there is no change in troponin during stress testing if you're not going to get ischemic during stress testing despite having coronary disease. So this could be a very neat test that can be used in the emergency room, for example, to distinguish people who are likely to have ischemia versus those who are likely not to have ischemia just by measuring baseline high-sense troponin and triaging them from having stress testing. So in terms of high-sense troponin then, and ischemia, myocardial ischemia during mental and physical stress is associated with higher resting levels of troponin. High-sense troponin levels are increased after physical stress-induced myocardial ischemia. And high-sense troponin levels in patients with coronary disease may be a marker of repeated chronic ischemic burden during normal daily life, say during psychological and physical stress. In terms of patients with coronary artery disease, higher troponin levels are associated with underlying burden of coronary atherosclerosis. They are associated with more rapid progression of underlying coronary atherosclerosis, and they are also associated with higher risk of incident events, even in those who have renal insufficiency. So we've talked about then all these biomarkers that elaborate risk based on these pathophysiologic processes that we have understood for many years. And before, I've also talked to you about repair and regeneration factors that we measure as circulating levels of progenitor cells. And just to remind you that both the hematopoietic progenitors as well as endothelial progenitor cell levels are highly predictive of future outcomes, and the combination of those two help as well. So I'm not going to dwell on this because we've done this before and I don't have time, but just to show you that the biomarker way of measuring risk is going to be extensive as we go further and further into these. We are now doing metabolomics and expression studies to really find out pathways that we never knew existed, so that might also help us further distinguish risk. So we have now this whole paradigm where we are stuck here clinically, but we have all these other things that are being discovered and that will be discovered. Some of these are ready for prime time, except they're not actually available, that have been shown to be highly predictive. So here's what I've shown you, biomarker risk score based on these biomarkers that can distinguish patients' risk. And so nobody's actually thinking about this, obviously, but when you do talk about this, people say, well, you've shown this, does it really work elsewhere, and what's the strength of this evidence, and have you validated this? So we did. We at least validated 3 of these biomarkers, and the 4th one also has been validated now, and this is in the Barry-2D trial. Barry-2D, remember, is a trial of diabetics with coronary disease who were either put into medical therapy or revascularization, and they were randomized also to insulin sensitizing versus providing regimens. They were aggressively treated and with medical therapy and lifestyle modification, and then they were followed. And as you know, there was no difference in outcomes whether they were medical or not. So we looked at these 3 biomarkers by the cutoffs that we had determined in the Emory cohort, and we found exactly the same thing. People who had low biomarker risk score, 0, had much better outcome in Barry-2D in terms of their mortality going forwards. Look at the difference, 6 to 26%. These were people being treated beautifully, right? They'd spent $80 million, and every person had 2 nurses looking after them. And they had death and MI rate was like this, cardiac death rate was like this. And so what's the strength of evidence? The multi-marker risk score based on CRP, FTP, HSP70 is validated, predictor of adverse outcomes in patients with coronary artery disease, now in 2 different cohorts, in over 6,000 patients with 800 deaths and MIs. So this is more than twice as many events that occurred in Framingham, when Framingham risk score was thrust upon us. And also it has 10 times more events than MESA has, for example, with calcium score. So we are now able to predict people who, based on these biomarkers, who have acute progression and people who have more stable chronic progression of disease. So the next question is, does it matter? Who cares? Okay, you can do this, it's nice, it's not available, what do I do with this information? And how does it change treatment? Because up until now, you measured things because you could treat those things. We do an angiogram, so we find a stenosis, and we can treat it. But here you're giving us all these funny things that we can't even pronounce, and then you're saying that you have to treat based on this. How does that work? So let's see what we do currently and be honest about it. we're told not to target LDL. So even though we think we target LDL, we're told not to target LDL. Larry's sitting there, he's smiling. So we give high dose statin or not so high dose statin and then do nothing. We don't treat HDL because we don't know what to do about it. We target glucose. At least the endocrinologist amongst us target glucose, knowing that it doesn't do anything to microvascular events, but we target it anyway, and when we target it too much, we know that we increase cardiovascular risk. We target blood pressure, but half the things that we do for blood pressure actually make arterial stiffness worse, and we know that when you normalize blood pressure in a person with a history of hypertension, it doesn't normalize their risk. We don't target platelet function, even though we throw aspirin and Plavix at people. We don't target for weight and exercise targets. We don't do routine rehab. We don't look for stress or depression because we don't know what to do with it when we find it. And we certainly don't do anything about social determinants of disease, which are highly relevant in terms of outcomes. In fact, 40% of the drugs that we give to patients, they don't take. That's the data. Believe it or not. It's not your patients, but other people's patients. So what can be done about this? What can you do with this biomarker risk score? So in Barry 2D, remember that they did this intensive lifestyle and everybody got on everything, and their glucose was normalized, their blood pressure was normalized, they got on statins. So what happened after 1 year? So this is data in about 1,400 people, even though they look like 3 bar graphs. This is 1,400 people who were measured for these biomarkers at baseline and after 1 year of this intense therapy. So notice how CRP comes down, FTP comes down, hs. So all of these biomarkers come down, and they come down significantly. But this is the important diagram. These are people now who at baseline had low biomarker risk score of 0, 1 based on these biomarkers, the green ones. The red ones are 20% of people who had high biomarker risk score to begin with. After 1 year, if you started off low, 90% of them, roughly 9 in 10, remained low. But 1 in 10 actually became high in terms of their biomarkers. Similarly, after this intensive therapy, those people who started high, 80% of them converted to being normal, at least in terms of their biomarkers, and then about 1 in 4 or 1 in 5 remained high. Does that really matter? So here are now outcomes with a landmark analysis. So this is up to 12 months. Then you measure these biomarkers again, right, at 1 year. And now we're looking at, based on the biomarker risk score at 1 year, in those who had low biomarker risk score versus those who had high biomarker risk score. So it shows that people who had low biomarker risk score, where they were reclassified based on all this therapy that occurred. If you were made to be low, you converted, then you had lower risk than if you converted to a high biomarker risk score. So what that means is that aggressive medical therapy and risk factor control, the usual therapy, is associated with significant longitudinal decline in these biomarkers. So you don't need to have new treatments for CRP or anything. That remeasurement of the risk score after institution of aggressive risk factor control and medical therapy also provides important prognostic information, and that a decrease in risk score is indicative of better prognosis. And the implication is that this risk score is a validated and modifiable test that can predict cardiovascular outcomes, and that serial measurements of this risk score may be employed by physicians to risk stratify patients and to titrate therapy. So we really don't need new therapies. You just need to use the ones that you have, but target them in the right way to the right individual. And perhaps giving information like this to the patient might actually make a difference. So at this point, if I asked all of you here who look after patients that if we were to provide this test tomorrow, would you do it? We had one hand go up.
What's the question?
If we provide this test, would you use it on your patients? It's not available. So I'll end there, but basically we are targeting with these drugs and interventions, but are we on target? That's that. Whereas you might do this if you use your biomarkers. Okay, well, here's who we need to thank for producing all this data over the years. This is a very large population, a lot of fellows. These are current fellows are listed at the top of the list, and whose data I'm actually showing you. Many people who help with the Biobank. This is actually a list of individuals. It's probably not a complete list over the last 5 years who've worked on the Biobank, 80 people. And these are other collaborators who helped make this all happen. Thank you very much for your attention.
Great, thanks, Arshed. So I guess biomarkers are a form of signals of what may be going on, and I guess if you had the low biomarker group, you might be able to identify a group that did not need treatment. But if you had the higher biomarker group, the vast majority of those patients still do not have events, and I guess the risk would be that you end up identifying a group that you're saying is at higher risk, and now that's going to trigger somebody to do additional testing to go to more intensive imaging and that type of thing. And I mean, that's been the history in cardiovascular disease, I think, is that when we see a higher risk population, we start thinking about their atypical symptoms in a different way. So what will it take to make these things more likely to be used, more likely to be approved? How would you design a study to prove that? Where do we go forward with this?
So two things. One is that it doesn't inspire more imaging, because what we have also shown is that cabbaging and angioplasty does not change your biomarker risk score. So you would be mandated not to go down that pathway of trying to find out more about them. The find out more is that they have vulnerable plaque and they have lots of atherosclerosis, and that's going to lead to events and to renal events and to heart failure events. These are nothing to do with more imaging. So I think that's true. That's what we would do, because that's what we always do. But that you would be restrained from doing that because it doesn't help. This is beyond imaging and your angiography, right? This is to do with your heart failure functional class or your BNP. It's beyond all of that. So I think all this is saying is that you need to intensify therapy in the ones that have high risk. And I'm not sure why you would be reluctant in taking a group of people who have 22% risk in the first year and being intensive with them, not knowing which 22% it is out of the 100, right? Because you won't have that many of them. And you would have, based on Barry 2D, 80% chance of normalizing them within, next time you measure them. So to me, it would seem a very obvious thing to do, but we would have to prove it, like you said. On the other hand, those people, the third of the population that has extremely low biomarker risk score, you would leave alone and not harass them because they're not taking the medicines, because whatever they're doing the right thing, as far as we know. So I think it helps you at both ends of the spectrum and should make costs less and events less as well. So the study that we'd like to do is as follows. We would take one Emory hospital and measure everybody and give all the physicians and train them how to use the biomarker risk score. We develop an algorithm so that you would have a rate of risk for that individual patient, because you can individualize risk, right? You can put them on a line. We'll also use the baseline, the LVEF and the coronary disease and the age, blah, blah, and have an actual number with a confidence interval of what their risk is in the next year or next 5 years. And then we will give you and the patient that information, that they have such and such a biomarker risk score based on this, and that if you intensify the therapy multiple ways, just like Barry 2D did, for example, you should be able to bring this down, and then 3 months later you'll measure their levels again and know where you are. In the second Emory hospital, you'll do none of that. You'll just take them, what we are doing now, which we'll just measure them and see what the outcomes are. And over a year or two, and we'll look to see what happened. That would be the study. So that would actually tell you within the healthcare system whether we can educate people, create these algorithms, intensify therapy, what the cost of this will be, what the acceptance would be, what the patients think, what the physicians think. So I think that would be a neat trial.
Arshed, that's fantastic. That'd be a great trial. Where would you start with the patients? Would it be again in the cath lab, or are you talking about across the board patients who have not presented? Because I have another question that relates to the substrate that you're dealing with, because in your database they're all coming out of the cath lab.
Yeah. So that's what we've done, just because that's what we've done. It's a great place to recruit patients because the cath lab group is so generous, and patients are ready to make a change, and they've had all of this done to them. It's where you are planning their treatment change, maybe a once in a lifetime event that occurs. Clinic would be the other place, taking people with stable coronary artery disease who are going through our clinics. Heart failure would be another crowd. We could do it either way. I'm not sure because we just don't have that experience as to what the risk score distribution would be in a population that's stable in clinic. It may be a less sick population potentially. So we need people who are at high risk that are also going through our hands that we could influence.
My follow-up question, or not follow-up, the other question was, you've identified in the database non-significant coronary disease, non-obstructive. Is it possible to look at the cath reports that were called no coronary disease?
Zero.
It's not real, but
less than 10%.
Normal coronary arteriogram. I mean, you have reports that come out normal coronary. Of course, that's eye of the beholder. But you've got all this great information about calcium score and how that relates, which I interpret as people who don't have atherosclerosis. And in the cath lab, we don't. It's not angiogram's not a very good test for atherosclerosis. But I wonder if there's a difference between if normal coronary arteriogram in any way is a surrogate for a zero calcium score or close to it, and whether if you break that, you'd get another level of risk that would be so low.
We did that, and we read, at least for the first 3,000 patients, we read all the normal coronary angiograms. To be sure, just to do that, what you just said. Because even for genomic reasons, which is why we created the database, you really need to have a control group. We thought this would be the best control group where we read them and decide that there is no coronary disease. It also turns out that it's a very dirty cohort in the cath lab, and dirty in the sense that they all have HFpEF or HFrEF, they are dilated cardiomyopathies. It's a mixed bag that goes through, which we call normal coronary angiograms. Some of them we expect to be normal because they actually EF is 2% and that kind of thing. So you have to be very careful how you do that. And the more you become careful, you end up with young women, which also is a problem, because that's what happens, right? Lots of chest pain, and you do lots of normal coronary angiograms in that group. So I don't know how to create that very normal group from within the cath lab, but what's important that I didn't show you was that if you look at the prediction with these biomarkers in the people who have significant disease, so-called above 50 versus below 50, it's far more predictive in the people without significant coronary artery disease. The biomarkers are.
Sorry, I guess one sort of obvious question is whether doing this in people that have any connection to a cardiologist is sort of the right strategy, right? So in many ways, by the time they get plugged into a cardiologist, the greatest potential of this therapy or this potential way of thinking about treatment has probably been lost. Doesn't mean it's not helpful. I mean, you showed persuasively that you can change people's risk profiles, but it seems to me that the most exciting way to use this would be to do something where you forget cardiology, but embed this within decision support mechanisms for primary care and this kind of thing, where we're in a health system that has an enormous number of primary care clinics. If you could find ways to sort of do incremental implementation models like step-wedge designs, those kinds of things within the primary care outpatient context, you could get some really cool, potentially very persuasive data. That's obviously not simple to do, but the beauty.
But don't you think you have to demonstrate it first?
So that was actually my follow-up question: is what does it take? And you and I have talked about this before. I think it's a really interesting issue. What does it take to sort of justify these kinds of what kinds of data do you have to justify these kinds of approaches in a trial setting like that? I think
Well, I think the simple way to show this would be that you can modify risk with the biomarker risk score by providing information. That would be the lowest hanging fruit, and you will get data on every single patient, because I've told the physician, I've told the patient, they start taking their meds and they get religion, and they intensify something or the other, and then you will have it measured and it'll be lower. And you can show that just by doing that you can make it happen, and that would be low hanging fruit. Now, the real proof would be following these people over a couple of years and showing, but we'll need thousands to do that, to be able to get event rate curves to start to look different. So that would be the sort of the ultimate goal. So a two-step thing. But I think just showing modification and then alluding to the fact that when you modify, you improve risk based on other evidence might be a sort of second best way of doing it.
Arshed, a couple of comments. We published a paper in JACC in 2015 from Berry 2D showing that those who received optimal lifestyle, behavioral, and medical therapy had better outcomes, without the measurement of biomarkers. And so it correlated with both mortality and morbidity. Now, in a real-world setting, unfortunately, our diabetics with obstructive coronary disease do not get optimal medical therapy and lifestyle therapy, and we know that as well. And so this type of paradigm might be beneficial as we move to new healthcare delivery patterns. And we're going to have bundled payments for these patients with secondary prevention, And so if we can further risk stratify them, we can better decide potentially who has home-based comprehensive risk reduction or e-health, m-health, telemedicine. But those who are in the highest of the highest risk group, that's where we're really going to intensify and invest our efforts. So that's a concept called best buys through the World Health Organization. And that might be this high-risk group who gets the kitchen sink. And we're watching them more carefully and closely because we don't want them back in the hospital or back on the cath lab table.
We looked at this relationship between what happened with blood pressure and with insulin and all of those things in Berry 2D and what happened to each of the biomarkers. It's hard to do, as you can imagine, because everybody's having everything done, and you're trying to correlate a change in one thing with a change in a particular biomarker. But you can do that. And for example, CRP was related more to blood pressure reduction, and FDP was more related to insulin, glucose improvement, and so on. But I'm not sure we can say that, and anybody will publish it, because it's just done in a multifactorial way. And I think we need to get away from that. We need to get away from, I'll use this single drug and see what comes down, because really we have to do everything to these people. That's what we do. And it might be better to do it, as you say, in this sort of total management. But be intensive in that 12% of the population that are very high risk, and stop badgering people, the 30% who don't need to be badgered, into submission.
And can I just make one quick comment? I know we're running late. So first of all, really congratulations, because this is taking science and bringing it to clinical practice. And I think that the risk factors and the data you've shown, at least in the cath lab population, is extremely compelling. And as you know, Emory Healthcare and actually all large healthcare organizations, as Larry points out, are extremely interested in finding ways to reduce recurrent admissions, and there may be, synergies with healthcare systems to implement such a thing. The one thing I would say is, the low-risk people that you found with the very low biomarker profile, they too are often going to get treated with the standard therapy. So I'm not sure that these data suggest that you can peel away therapy on them because your observations are on existing therapies.
I'm saying you would peel away, you would just leave them alone.
You say you stop badgering them. I thought you meant by that take him off meds, but maybe
No.
I misread that. But,
No.
but the other point is that even in your Berry 2D study, which I think was extremely interesting to basically validate it in a different cohort, the folks that transitioned from high risk to low risk biomarkers had a much lower risk going forward, but continued to have some events, obviously. And so I think that one of the conclusions you made is, okay, we've got all the treatments we need. And the answer is yes, there's a lot of progress we can make with further risk stratifying, but we may not have all the treatments we need, and more work needs to be done on the therapy side as well. But I think overall, I think this should be very exciting for us, and personally, I think as a health system, we should see how we can look to implementing some of this if we think we're ready for that. I mean, I'm not even sure we need another large randomized trial. There's so many things that we do based on a lot less data that cost a lot more. So I do think we should get together and figure out how to implement some of this.
I think this field suffers from the fact that nobody can make money off of this.
The preceding program is copyrighted by Emory University.